It's been just over a year since we began a search for the successor to Dr. Richard Jonas, and I'm very pleased that Dr. Dudicum has arrived, and he's here today to tell us a little bit about himself and his practice and give us a little bit of his observations as he begins his new part of this career in Washington, D.C. Dr. Dudicum, tell us a little bit, I'll call you Yves. Tell us a little bit, Yves, about your background in training in congenital heart surgery and how you got started on this path.
I was born in Canada. My father was an engineer, and in the end of the 50s, he migrated to Canada to work, came back to marry my mom, and then as an engineer, traveled a lot. So my first years, my first memories start in Iraq, in Baghdad. And then we went back to Belgium, and I did most of my education years in Belgium. I went to medicine, and my path toward pediatric cardiac surgery was a very progressive one. I was damn sure I wanted to be a surgeon in the middle of my training. And then from general surgery, I quickly veered to vascular surgery. Then I wanted to become a cardiac surgeon. And I like the most technically challenging discipline. That's why I probably veered to a pediatric cardiac surgery. I think it was being more complete as a cardiac surgeon, being a pediatric cardiac surgeon than an adult cardiac surgeon. But that came just progressively.
So tell us a little bit about the Canada experience. This was in Toronto, is that right? You know, which is really one of the leading hospitals in North America, certainly. What was your experience there, and who were some of the special people that influenced your career?
My big mentor, and I was really influenced by him, was Dr. Tyrone David. I reflect a lot about that because when I got to him, he was approximately my age, actually. And so he was becoming the leading figure in his field. And the people I trained with said, there is this new guy in Canada. If you want to do some innovative surgery, you should go and watch him and train with him. And that's why I went to see him. He said to me a thing that I constantly repeat that year. And he said to me, your training is like a pyramid. The wider the base, the higher you get. And I always remember that. And I think it characterized my training pretty well because Belgium was very strong in coronary surgery, valve surgery, artificial hearts. In Canada, I got the best of aortic valve surgery, mitral valve surgery. Tyrone David has become the leading figure in valve repair for more than 3 decades now.
And you must have also had some experience with ventricular assist devices and mechanical support of the circulation in Toronto as well.
I had spent 1 year in South Africa, and so I was one of the few guys who mastered medical English. So every time the team were coming, they were inviting me in the lab, and so I got my hands on, and so I quickly became the number 2 of the unit in terms of assist device.
So after you left Toronto, you go back to Belgium, but then you find yourself in London at one of the world's great children's hospitals at Great Ormond Street, and there you met Marc de Laval. So tell me about how you arrived in London and a little bit about Professor de Laval.
I have a little story about that. There was a crucial moment when I came back from Toronto to Belgium about my choice of becoming a pediatric heart surgeon. And I had no intention at the time when I came back from Toronto to become a pediatric heart surgeon, but the job was to do part-time pediatrics. And so Professor Chaland was the guy who taught me cardiac surgery. He was a professor in the Faculty of Medicine. And he really liked pediatric heart surgery. Solid, really good surgeon. And it was close to his heart. So one evening, everybody had gone from the offices. He came back. He was retired at a stage. And he asked me, Yves, what about pediatric heart surgery? Do you like it? I said, doesn't matter whether I like it or not. I mean, there's no job. I mean, too small number of patients. I mean, what's the point of me liking it or not? But then he said to me, that's not what I asked. I said, do you like it? And I stepped back and I thought, yeah, I like it. It's a nice surgery. And he said to me then, if you like it, you should train in it. So you should invest in your training in pediatric cardiac surgery. The patients all will come. They all will come. And so I came back to my wife that evening, I said to her, I think I'm going to train in pediatric cardiac surgery. She said, no, because we had been by that time in Toronto, came back, moved all the times. And then she got to the idea. And so Marc de Laval was godfathering our unit. And so I came to him, and he's very proud, but he trained all Belgian pediatric heart surgeons because he felt a bit guilty to have left the country. So he wanted to give back to the country. Didn't work so much for me because I left after a few years, but I'd made my contribution to Belgium as well. And JOS was an amazing place. I thought, it's one of these places where, as a fellow, as a trainee, you had a voice. So that was a place where you openly discuss all ideas. So you discussed case, and they would invite people who were more junior, like me, to express their view, ask questions. There was this communication. De Laval was a fantastic surgeon, but above all, he was a great spirit and would always take the right decision during the operation. And he was admirable at that level. And he had a work ethics and a way to make decisions for families and patients that was absolutely unique. It remains a beacon of inspiration for me.
So after you left London, you then arrived at another famous institution for treatment of congenital heart disease at the Royal Children's Hospital in Melbourne. What led you to Melbourne, Australia?
So when I trained with this Belgian pediatric heart surgeon, I asked this stupid question that only cardiac surgeon would ask because we're driven by ego. And I said, who do you think is the best cardiac surgeon in the world right now? And at the time, and that was the end of the 90s, that surgeon thought a little bit and said, probably Roger Mee in Melbourne. And so Melbourne, I don't know if it's the best or not, that's irrelevant, but Melbourne has created a generation of superb surgeons. Roger Mee, Bill Brown, Sunji Sano, and every people who went there had a reputation of being good technicians. After a few years of training in London, I was so frustrated. Every time I was going to an international meetings, I was seeing video of surgery. I said, give me the instruments. I mean, I think I can do better. Give me the patience. But I didn't have the patience to flourish as a surgeon technically. And for research as well, I thought I could do a lot more than I was doing in Belgium. And so they advertised the job in Melbourne. I applied and I was selected for the job. And my wife kindly agreed to move with 5 kids between 6 months and 8 years of age, which is quite admirable, without knowing anybody in Australia, no connection. So that was a big move.
I should also point out that Dr. Jonas, who was our former chief of cardiac surgery here, also did much of his training in Melbourne as well, and also, I think, did spend time and has enormous respect for Roger Mee. I think he also spent time with Brian Barrett Boys and other famous people who were founders of congenital heart surgery. So we have to talk a little bit about your family and raising a family in Australia. And tell us a little bit about your wife and children and some of their attitudes and where they are here, and maybe what advice they gave you about coming to the United States.
An immigration process is not easy. So I moved there without any contact, any support, no grandparents to look after the kids. But one thing that was positive from that experience is the fact that anytime I had free, it was not for my social life, not to see the aunt and the cousin. Every minute I have free in my very, very busy life over that whole time was to be with my kids. And I'm an outdoor person, so we spend a lot of time with 5 kids. It's very difficult. You try to book a place in a resort, running around, disturb everybody. So camping is ideal for that. So we went into the nature. The whole kid, you drop the stuff. All kids ramp around in the woods, and they have fantastic memories of that. One of the things I was the proudest, I think, in my life is my second daughter recently told me, all my friends, so she was saying, all her friends were asking, your dad is a cardiac surgeon. I mean, you must not have seen him a lot. And she thought about it, she said, and she answered to her friends, I don't know, I never felt that I not had enough time with him. And I think that's because all the holidays and all the weekends and all the time I had free was just for my family. So I sacrificed on the social life, but so we have a very united family. So now my first three are staying in Australia. My kids are spread between 17 and 26 now.
So you raised a great family in Australia. I heard you mention camping, but as I recall, one of the first times we met, I heard you talking about cave diving. Tell us a little bit about your hobby in that arena.
Yeah, that talk was to make the comparison between cave diving and pediatric cardiac surgery, and I found out quite an interesting number of similar points. If I don't regret anything in my life, but if there was something that I could do differently, is I would love to have spent more time outdoors. I thrive when I grew up on the countryside. I thrive when I'm under the woods, and I need the nature. And so working in a closed hospital environment is not always easy for me. And I'm living in a difficult job. There's a lot of pressure of a lot of different sorts. And I find out that I need the stimulation to get rid of these worries and concerns. So I need something that is as exciting. And the people would describe me as an adrenaline seeker, and I don't know exactly. It just came to me like that. But my main passion is scuba diving. And I came to cave diving. It's a question of, it depends on the elements, but in 3 dimension, in a completely different world, and you have to be focused on everything at the same time. There's a lot of preparation, and it's completely involved. And so when I do this kind of sports, when I'm outdoors in adverse condition, it washes out everything in my brain. So I know I need that, and I know myself well enough that on regular interval, sometimes I have a pile of works to do in my email box, but I know that now is the time I have to get out and do something physical in the nature.
So here you are in Australia. You've raised your family. They're leaving school now, going on to college. What turned your attention to the possibility of coming for your professional career to North America?
So I had a very good job in Australia. Some people say one of the best job or the best job in the world in pediatric cardiac surgery. It's a good lifestyle. I was living 150 meters from the beach. A lot of practice, lots of complex cases. My research was booming. What I found myself with is that after a few years, I had achieved my goals. I had proven that technically I was at the height of what I wanted to achieve. And I had an even much larger academic production than I would ever thought. And so I find myself in a way where I could predict my trajectory for the following 10 or 15 years. But I think that I can do bigger things than that. So it's a challenge. I'm not sure. But I think I have what it takes to change my field and influence my field. I've learned a lot of things, and I think that I can spread the things that I've learned throughout the world. But when you go to meeting, I come from Australia, and they hear the guy from Australia giving a talk. Oh, that's nice, and so it doesn't change things. Medicine is still predominantly English and North American English. You want to change the specialty, you have to be in one big North American center. And so that's one of my challenges. I have a limited number of years in my career to achieve my goal. And Australia is a fantastic country, but not the best country for innovation. They tend to do like Americans do, very much. And so I thought that if I find a place where I believed I could drive innovations, new strategies, more than in Australia, then I would be interested to move. But this was an important criteria.
So what were your first impressions when you came to visit Washington, D.C. for the first time, here at Children's National Hospital?
In all honesty, I was on my way to another job. So there were people who had tried to attract me, and I was ready to take the position. And I was just passing by Washington, just have a look on the way. That is a little bit the story, and I didn't expect to like it so much. And so I spent a very short visit, and I knew that it had some of the characteristics of the centers that I would be looking for in North America. I had enough bypass cases, enough cases to operate, an access to heart transplantation and artificial heart. But the things that I found out that there was a lot more academic interest in this institution that I expected. They were really thriving, willing to have some development, and an obsession about innovation that really resonated to me. The other thing is that when you visit a place, you have quickly a feeling about the culture of the place. And very rapidly, within 24 hours, I felt that the people were happy here. I thought it was a caring environment. And that was important to me. And after a bit more than 24 hours, I spent an evening with Ricardo Munoz and Charlie Beroul, and we spent the evening on the restaurant. We barely talk about any medical stuff. And I came out of the restaurant. It was December, pouring rain in Georgetown. And I walked for an hour and I thought, gee, I can work here tomorrow. Sounds nice. I had that, connection. And so it dawned on me that this might be the right job.
So you've been here a few weeks. It's now just past the middle of the winter. What are you most looking forward to as your family arrives and hopefully we see fewer COVID-19 patients as we begin to approach our future in the summer of 2021?
I haven't seen much of the town right now. I've seen a little bit of Georgetown and probably been 3 times in a restaurant terrace in all this time. But I look forward to look at the city. The striking thing for me when I arrive is the similarity with old Europe. There are parts of Washington that looks exactly the same than Brussels, same tunnel and statues, and I can, imagine myself back home. And it's funny, it's an intermediate step. Coming from Australia, I thought that I was going to another country, but I have a little bit of the feeling of getting back closer to Europe. Plus the park, I'm very keen on showing the family and friends the autumn. I haven't seen the spring, which will be spectacular, I've been saying, but the autumn was magnificent. I mean, the trees in the Shenandoah National Park and in the city there's something special with North America, I think. I like to go to museum once a year, to the opera, having some outings, and I look forward to a normal life with that. Then we have a dog. At some stage, the dog will be coming, and so we picked a house close to the park. So me and my wife on the weekend, usually we go for long walks, and so there's going to be a lot of nice long walks. I think that I'm planning to go from the place we are. We can walk to Arlington and visit and walk along the Potomac, and I think it's going to be nice.
Well, we're certainly pleased that the first visit made that connection for you. And I know we had you back in a subsequent visit a very short time later, and the search committee was extremely pleased, not only with the demonstrated clinical excellence in your surgical outcomes, but also in your leadership skills, your collaborative and respectful and empathetic style. Those were very important things to our institution. So you arrived in mid-September here in Washington, D.C. You've had several weeks now to gain some experience with the nature of our patient population. We're aware and very sensitive to the fact that in Washington, D.C., we have a high prematurity rate in our births. The children here in Washington, D.C. are born too often prematurely, and that is a driver for some of the technical challenges in congenital heart disease. With your emphasis on the single ventricle, with surgery and innovation in the newborn in particular, what's your experience been like in the first few weeks here in Washington?
So I quite rapidly realized that it was a different population than what I was used to in Australia. So in Australia, we had the most complex heart failure patient, but grossly speaking, we were operating the disease coming from an entire population. And the spectrum of disease that I've been facing here in DC is different. So they're not the all-comers with congenital heart disease. They're more specialized. And so we have the babies who, as you said, are premature, the baby who have more comorbidities, other affection afflicting them. And we were taking on patients that I had not seen before, honestly. So I haven't seen this tiny baby surviving to the stage where you can do surgery. 1.1 kilo, no coronary arteries, 1.1 kilo hypoplastic left heart syndrome, and you manage to get this patient to the weight, the age where you can do something. And I'm thriving for change, learning, and I have to say I'm learning because these babies' hearts are different. They're thicker, they don't have the same elasticity. It gives a whole spectrum of problem that I was not used to. But that's the exciting bit. I think it's because I think I bring a technical expertise and an ease, I think, in operating tiny babies to a center who's excellent in keeping this tiny baby alive. And so I think the combination of both will be amazing.
So it's really been our emphasis over the past many years to promote the notion of neonatology, neonatal care, intensive care of the child right after they're born and before they're born, children with congenital heart disease and other complex diseases. But we have a team here of what's nearly 40 cardiologists. There are 14 or 15 cardiology fellows. There are critical care fellows, a 26-bed cardiac ICU. But I'm impressed with the way the team has mentioned to me your willingness to do innovative procedures and to have very good outcomes with procedures that might be considered elsewhere as risky. As I recall, in the last 2 or 3 weeks, there's been a Nakaido procedure. You've done a neonatal Ross procedure and other complex procedures. What's your attitude toward risk-taking and how you distribute those risks over the life of the baby?
So I don't hesitate in terms of risk. My profile in my personal life and my outdoors activity, the type of job that I have, my personality, everything is clear in me that I'm happy to take risk. I'm happy to expose myself. I'm happy to take risk. It has to be not stupid though. And so that's where the teamwork is really important. We have today a discussion of a 2.5 kilo baby where we have two options. One option is where we could wait a bit longer and one option is where we can operate directly. I'm happy to operate directly on a very complex operation in this small newborn baby, but I'm happy equally to have the whole team working on that baby. I think that my vision of cardiac surgery is that the outcomes you have is not the results of one person. I am not taking risk. The whole team take the risk. We're all together in that stuff. So at the decision now, the intensivist, the cardiologist, myself, the referring cardiologist, we're all participating in the decision. I'm going to do the surgery. What is important for me, and it took me a while to understand that, is that I'm very relaxed about risk because I know that I'm doing the absolute best for the patient. So if I summarize, and that has gone through my mind many times, honestly, I had the best possible training in terms of adult pediatric cardiac surgery. It's very important for me to give the best to the patient. So I don't drink alcohol. I don't drink coffee before operating. I take care to have a good sleep. I exercise every day. So and you know that I have a discipline of a monk. And so I have the best training. I know that I'm more than half decent in what I'm doing. I know that when I go and offer surgery to the patients, I've given the absolute best I can. And I don't think anybody can compete on that. And so provided that the decision-making is the decision of the team, we all together in that, and I've given my best. So am I taking risk? Yes, I'm taking risk, but in a measured way.
The culture of our institution is led by our president and CEO, Dr. Kurt Newman, a surgeon who has continuously reminded us if we make our decisions with the child and the family at the center of our decision making, we put our feet into their shoes and say, if I were they, what decision would I make? Then that really helps drive the institution to the right goals. So I notice when you walk around the unit or you're making rounds in the intensive care unit, you expect your team to know the name of the baby. It's too easy for us to talk about maybe the TGA in bed space 10 or baby girl Smith, but you expect your team to know not only the last name of the baby or the child, but the first name as well, and connect with that child and the family. Tell us a little bit about your philosophy toward the family and treating the whole family.
What I want is that the parents and the family go here, and it's an extremely distressful moment, but this is their home when their kid is sick. And that's the one, I want them to feel that way. I want this environment to be as comforting as possible. I want this environment to be prone to healing. One of the things, as you said, knowing the baby by the first names. I mean, last week I went to a room and I had to, the nurse had to look back and to know what's the first name of the baby. And so I'll keep chasing the babies. Even some families give names to the fetus at a very early stage of pregnancy. And that fetus has a name, and so it should be respected. I tend to use, I have a difficult last name, so Dr. Yves is fine, and there's not a lot of Yves in pediatric cardiac surgery. So I said, if you remember Yves, you'll be able to track me down, you'll find me. The other thing is I like to do is that I talk to the kids as well. Starting at 10 or 12, they're independent person. First of all, when I talk to the kids, likely the mom and dad understand better what I explain because I'm explaining in a better way. And I think it's their condition. They should be part of it. For me, it's very important. It's not only providing best results, it's the way you do that. And it's the way, we work as a team too. It's very important for me to have perfect results. I want these centers to be the best one in North America or in the world, but not at all costs. I want it, the how we achieve that is very important to me too. I want the people to be happy to come at work in the morning. And if the people who are coming here are happy to come at work in the morning, the families will feel that too.
So the concept of regionalization of care for a child with congenital heart disease is pretty well advanced in other parts of the world, certainly in Australia. But regionalization of care is not so prevalent in the United States. At the same time, our search committee was very intent on finding a new cardiac surgery chief who was collaborative in their practice. Tell us how you view collaboration and regionalization of care in the Washington area in particular, and really around the country.
It is difficult to be in my position and not to speak for centralization of care. There's obvious data that if you do more patients in one big centers that is providing specialized care, you're going to have better results, especially in the high-end complexity cases. And that's what I want. People in my position, with my type of job, want to have regionalization. In my training, though, I have worked in scheme where smaller centers were doing good work and could work in collaboration with other centers who were doing more specialized care. And I think that this model can work. My vision is that you get a lot more by collaborating than by fighting each other. I don't see myself as competing in any devious way with any neighboring institutions. I know, and I hope that I will inspire that by being collaborative, everybody gets more than by working individually. And I found that with the Australia-New Zealand Fontan Registry, that's a registry that I create, the largest database of single ventricles, so the most complex heart disease patients in Australia and New Zealand. That initiative put together all centers from Australia and New Zealand and all the pediatric with the adult centers. And everybody individually got a lot more by working together. And that has been my model. It's a question of personality as well, I think, and I hope. I think that if you have good relationship between people, the people will understand, be less fearful to be stolen something, and then working together. I hope that then I can inspire that. When I talk about collaboration, there's regional collaboration, but if I may say, there's something interesting that's happening in North America now, I think, is that the first generation of pioneers were defending their turf, and there were different visions, different views, and there was a lot of fights. This is changing now. We're in a new era. The new generation of leaders in the field in pediatric heart surgery know each other well. We're not in this fight mood. And I think that, grossly speaking, North America, and that will rain down to more regional centers as well, there's a much more collaborative spirit than 15, 20 years ago. I think we'll see changes in North America, and I want to be part of that.
And I think from our hospital point of view, we are truly committed to collaboration in the region and to think of ways that we can work with other congenital heart centers and other congenital heart programs to make sure that the patients are allocated in a fashion where the best outcomes can be achieved. And through collaboration, we seek to improve outcomes and improve the care, keep it close to home, and make sure that we keep the patient and the family at the center of our decision-making.
If I may give a bit of perspective on the history of pediatric cardiac surgery, we went through different phases. The first phase was between the 60s and end of the 80s, 90s. This is the first development of the field. This is dominated by pioneers who do new things, invent operation. Everything was new all the time, and they tried a few patients, didn't work, try something else, and progress very rapidly. During that time period, the mortality for pediatric cardiac surgery decreased from 25% in best center, 50% sometimes, to barely 10, 5%. And so from the 90s to the mid-2000s, there were almost no new operations, but we perfected what we did. The mortality for all conditions decreased. And then we reached a plateau. So we went down on the mortality of the most extreme condition. For example, having a hypoplastic left heart or a single right ventricle, the weak pumping chamber, the mortality has decreased from 50% initially to 30%. And then it didn't get better. You look at all multicentric data, best centers, we all get a plateau. If you look at the other condition, the same. We make no progress in the mortality of the most severe congenital heart conditions.
And that's mortality looking over the first few months of life after the initial procedure.
Most of the mortality in congenital heart disease is within the first year of life, during the first step operations.
Tell us about your vision of the future, and in particular where you think congenital heart disease is going and what part of that future path you could help lead.
I think we now in a bit of a turning point, and I hope it's a turning point. And so now we're at the stage where we have to move forward. And the way to move forward is to have absolute best management for these conditions. We have to understand that we cannot play one thing, procrastinate, try something, and then try something else because it doesn't work. Everything has to be programmed. We have to have care pathway that is super clear. And I think that if we enforce that and spread that out in the community, we can gain a benefit. Then the other thing is we have to innovate. We have to have the courage to try new things. And right now, because of the medical litigation, the spirit we have, pediatric cardiac surgery is paralyzed by fear. The people are afraid of trying new things. And we have to change that. And I think that with the collaborative spirit that happens now, we might be able together to change this. But it's going to be very difficult for one person in one corner to change that. We have to do that all together. And that's the challenge for the years to come. But I think we are at a turning point. The other thing that happens right now is that there's two other things. We have created a new population of patients, is the patients with adult congenital heart disease. And we're just starting to understand how to care for them and look after them. And so there's new operations that are on the way for that. And then we're starting to understand that we have focused for most of the history of pediatric cardiac surgery on hearts. We've tried to have them surviving, not having too many operations. But the life content of the patient is not limited to their hearts. It's about their psychology, how they feel, what they achieve in life, their physical capacity. We have done close to nothing to make them fit. We just said, oh, you had an operation on the heart, don't do anything. And now we're realizing that it's all the opposite. We should train them, physically train them, so that they're in a better health condition and live longer and better. And so we're gonna have to start to have a holistic care of congenital heart disease. Look at their brain, their muscle, everything, not only the heart.
So let's talk a little bit about the Fontan Registry. You're the leader of the International Registry of the Fontan. What do you hope to do with that here in Washington, D.C. over the next few years?
So we blocked in the treatment for this severe condition after Fontan, the final operation that we do for this patient with single ventricle, because we haven't got the data. And there's different avenues of treatments, but everything goes down to we don't have the data. So today, the people who die or need a heart transplantation, close to 2/3 of them are seen by the cardiologist in a year before they're failing. And we're failing to identify that they're not well and they're gonna have a bad events coming very soon. So we have to identify their health. But in Australia and New Zealand, largest data set of these patients, 1,500 patients alive, 26 million inhabitants, populations. We had 4.5 patients dying or needing a heart transplantation as an average per year. You cannot accumulate science for that. So you need large data sets. We know that their valves are failing at a very rapid rate. The operations you can do that for that are new, so we have to find out the right operations. We don't know how much benefits we give to the patients. And again, you look at the data in Australia, 150 patients had an indication for surgery, probably. Only 15 are operated. How can I estimate risk benefits of anything I do? How can we find out when to do a heart transplantation, when to put a mechanical heart in this patient? We need more data. So that's what the International Fontan Registry will achieve. So with the IB is being put, and we're going to collect the data from all the major centers who have their data. So I hope that by 6 months to a year time, we'll have more than 6,000 patients' data in here in the Children's National.
And I know that's an effort that we're very much interested in supporting as well, to make it as successful as possible so we can mine that data and find better treatments for children with single ventricle illnesses, and especially after the Fontan operation. Earlier, you referred to the legacy of heart surgery here in Washington, D.C. at Children's National. And I know you had an opportunity to meet Dr. Richard Jonas, our emeritus chief of cardiac surgery. Tell us what your impressions were and the influence in the field that you've conveyed to me and others.
When I first saw Dr. Jonas in doing one of my first 2 visits here, I told him I would not have looked at the job if it wasn't for him. He was a legend. I've talked about these pioneers who created the field. He's one of the pioneers. He's one of the few who determined what to do and not to do in pediatric heart surgery. His teaching was enormous in all fields of pediatric heart surgery. And I knew of the existence of the centers from the time he started here. The other thing is that the most important research work I think he's done is on brain and heart surgery. He's the one who unveiled the fact that we had such an impact on brain by doing what we thought were conventional surgeries. And the beauty is that he's continued this work and is still now pursuing that research in collaboration with me in the Children's National. So there's a trial that is ongoing where we're investigating better ways to preserve the brain during the surgery that we do.
Speaking of collaborations, I think it's a great collaboration between the cardiac surgical unit and the cardiac research that's going on here, much of which is focused on the brain of children, the developing brain, in particular, the research that Dr. Jonas does. And I think the opportunity to build a strong clinical program with great clinical outcomes and collaborate with this kind of research that's laboratory-based as well as clinically based is really important to the future of children with congenital heart disease. And we're really looking forward to that collaboration. Tell us a little bit about the structure of the Children's National Heart Institute that attracted you here in Washington, D.C., in terms of its organization, the components of the Institute, and the way you feel that that structure enables you to accomplish your work more effectively.
It's striking. So immediately at the first contact with the hospital, I like the way that I could report directly to people who would make decisions. So you and first Ensigns, and directly after that, Kurt Newman, the CEO. That was amazing to me, and I lived through it. So I've seen how dynamic is this structure. It's amazing. Coming from, public health system, which have their advantages, no doubt, but to drive changes, that's the best scenario. So we have a heart institute with co-directors, cardiac surgeon, cardiologist, intensive care, cardiac anesthesia, cardiac nursing. We can take decision together, have a very short administration structure, and a very quick turnover in terms of decision making. For improvement and innovation, that's the absolute best.
So that does provide you with some authority, if you will, over the field in this hospital, but it also provides you with some accountability. You have accountability for the funds flow, not only just for the professional fee side of it, but also for many of the technical fees and hospital charges all come up through the Heart Institute for you and your other 2 co-directors, Dr. Barul and Dr. Munoz, to manage in close association with our nursing leadership there. So I think that is something that we across the country have tried to achieve, and we've worked hard to try to get that model here in Washington, D.C. So give us a glimpse of your vision for the next 5 years. What do you see in our future?
I keep repeating to people, I didn't come to Washington, D.C. to get a job. I had a very good job in Australia. I was working well. It's not a question of salary. I came here because I believe that I have the capacity to drive changes. And I want to test myself to see if I drive changes. Honestly speaking, if in 5 years' time, I find myself having a good job and things are working well, and we among the best center in the country, I think I will have failed my objectives. I want to be the best center, but that's not my objective. What I really want to, and what I came here for, is changing things. I want to influence practice. I want to make sure that we have a uniformization of practices in congenital heart surgery. I want to have new ideas, breaking the ceiling of the mortality in the first year of life of these babies. That's what I want to do. If in 5 years' time I look back and I'm just one of the best centers in a country, that will not be enough.
Well, we certainly look forward to partnering with you to achieve those objectives. We at Children's National Hospital want very much to change the lives of children with congenital heart disease for the better. And we think that with the partnership that you've brought here to Washington, we'll be able to accomplish that. Thank you, Dr. Dudicum.
I look forward to it.